The Royal Society of Medicine, we start with military efficiency. It's exactly 6 o'clock, so here we go. We have our panel in front of us. I'm Roger Kirby. I'm the current president of the RSM, and it's lovely to see you all here. So grateful. I think we've got 60 people coming here. Hopefully you will have got your deposits back, or if you haven't, you will get them back, we promise. So thank you for joining us. We're here to develop and expand on the knowledge that was gained from the very first section, which was last year, wasn't it, Linda, in the front there? Yeah, we've got 6 fantastic speakers. We've got Anthony Ordman. I've known Anthony for many, many years. We've got Dr. Prashant Vass, Elliot Nation, Julian Weiner, David Holenschultz-Schmidt, that was difficult to pronounce, and Joe Josh. Here's Joe, who probably the most important member of the panel, actually, apart from Hadi, who is the chairman, because Joe's the patient, and last year we started with a patient story, and we're going to hear, Joe says more than a patient story this evening, so we're really interested to hear that. Unfortunately, Stephanie K. Barrett, one of our former trustees, can't join us, but she's been kind enough to send us a short recording, so we'll hopefully see that on our screens. And after this, we'll take some questions from Slido, which you can add throughout the session by visiting slido.com and using the code. Oh, golly, do I have to read this out to you? You're not going to remember it. RSMCER05. Yeah, there we are. Yeah, just point your phones in that direction and it will hopefully pick it up. So the event's being recorded, and during the Q&A session, if you could use your microphones rather than shout from your seats, that would be ideal, because if you use the microphone, we'll be able to add that to the recording of the whole event. And at the end of the session, we'll have a QR code on the screen so you can fill in a survey. The surveys are really important to us in terms of feedback and improving what we do here. So I'm going to begin by thanking Alan Diamond. I hope, Alan, last year you were online, but then suddenly you disappeared, apparently, and then you rang Michelle, I think, on her mobile to say, I can't see anything, but tonight I hope the whole session will be available to you. And thank you, Alan, so much for this. We really, really appreciate your support for this event, to make it free for everybody who will get their £30 back, as I mentioned. So the Alan and Sheila Diamond Charitable Trust supported the evening, and it supports a range of charitable organisations which funding complements grants it's made to University College of Osteopathy for work in the same field. So with no further ado, I'm going to introduce Miss Linda Diamond. Linda, careful as you come up on the stage here, who's going to say a few words in honour of Sheila Diamond. Sadly, Sheila passed away just a few months ago. Over to you. And thank you very much, and thanks to everybody in the audience.
Ladies and gentlemen, first of all, I'd like to thank the Royal Society of Medicine for allowing me the opportunity to say a few words about my lovely sister-in-law, Sheila, in whose memory the Alan and Sheila Diamond Trust Fund has sponsored this evening. The inaugural Masterclass on painful neuropathies took place last year. Some of you may have attended it. And I had the pleasure at that time of collecting Sheila and bringing her here, and later driving her home. This time, unfortunately, I'm alone. Sheila sadly lost her fight against cancer in November last year. Always quietly effacing, being introduced to anyone, Sheila would immediately smile and look at you in such a way, showing that she was really interested in you and how could she help. She never spoke ill of anybody, would always make an excuse for somebody's bad behaviour. She even kept her calm when driving my brother and myself around in the car. Caring for her was her byline. She not only looked after her parents, but after her marriage to my brother Alan, when I was away travelling on business, she started to look after my parents. They absolutely adored her. And in fact, when out shopping at the supermarket one day, my mother said to the girl behind the cash till, "This is my daughter-in-law and I absolutely adore her." The rather startled girl said, Wow, I wish my mother-in-law thought that about me. Sheila's caring for others may have started at home, but she certainly didn't end there. More formally, she plays a central part in the Alan and Sheila Diamond Trust Fund in helping to raise funds for many good causes. She was an enthusiastic and tireless hostess at fundraising, raising receptions and private dinners held in their home. She also took personal interest in the careers of students who had benefited from the trust, and an equal interest in the institutions supported by the trust. But Sheila never wanted praise. She was more a Prince Philip and liked to walk 2 steps behind. Her charity side was also reflected in the quiet, unseen matter of her helping various people who might urgently need money. Hearing of the problem, Sheila would try and solve it quietly herself, or she would place a cheque or an envelope with some money in the person's hand, wanting no thanks. Sheila was well read. She preferred fact to fiction, and she loved listening to BBC Radio 4 Question Time. She would seriously read the daily papers once my brother had finished with them, and she would carefully cut out any articles she thought might be of interest to me. She loved to go for long walks in Regent's Park. On the few occasions that I went with her, I must admit, I made a beeline for the lift, absolutely exhausted, while Sheila would rush up the stairs and usually beat the lift. She will be greatly missed. I in particular miss her little texts that she used to send me. Nothing important, just wanted to see how you are. But you know, nothing sums up Sheila more than a newspaper cutting from the Sunday Times magazine, which I found in her handbag. Under the heading, Words of Wisdom, was the following: always be kind to people. Sheila certainly was. And the other one was, your actions can affect other people's lives. Think carefully before you act. Sheila certainly did that. Her actions brought great joy and in some cases great relief to many people who will bless her and remember her for many years to come. But you know, I can hear her saying, that's quite enough, Linda. So I will end here. Thank you for listening and enjoy the rest of the evening.
My name is Jo Josh. If you read the programme, you will already know that. You will know that I am the patient, the person who actually has neuropathy and can share that sheer joy with all of you. I am actually, like every other patient, an awful lot of other things too. I've actually got a really useful skill set. I'm a communications professional, and in the last 30 years or so, I have worked in both print and broadcast media, in public relations, in crisis management and strategic consultancy for global businesses and the odd government. And in the last decade, I have focused on health and medical communications. I've also been a lay member of, and then vice chair of, a NICE committee. I'm involved in various research studies, and I work with doctors every day, which means that I have become a sort of hybrid being, somewhere between patient, researcher, medic, and activist, armed with knowledge gained through writing about and editing the work of some very clever people indeed. Since 2017, I've been the communications officer for the British HIV Association, while simultaneously doing an awful lot for not a lot for various voluntary sector organisations. I've become a sort of expert at translating medical advice and science into bloke in the pub speak, if you know what I mean. This really came into its own in the COVID pandemic, when the excellent RSM updates were always available on a weekly basis. I also use my communication skills in the pain sector. For example, translating last year research papers into plain English for the International Association for the Study of Pain. I've learned a lot about the search for successful pain management through involvement with projects such as the Partnership for Assessment and Investigation of Neuropathic Pain, Studies Tracking Outcomes, Risks and Mechanisms, or PAINSTORM. And I can't see her, but I thought Leslie Colvin was due to be on this panel, and so I was going to say she would have told you a lot more about it. I suppose some of it may therefore be up to me, which will not be as good. I'm one of 3 patient partners in this multifaceted 3-year research program, and it's exploring the mechanisms and the potential causes of neuropathies, including conditions ranging from diabetes, chemotherapy and trauma to my own area, which is HIV. I'm also a founder member of the Global HIV Pain Task Force, which is a collaborative which has recently conducted a survey of people living with neuropathic pain. It is variously estimated that between 22 and 44% of people with HIV are going to be affected by distal symmetric polyneuropathy. I just happen to be one of them. I'm here to share my own experience, but also to try to share the experience of others who have neuropathy for other reasons, because of other conditions. And can I just stop there to ask, how many people here actually suffer from neuropathy? Yay! There are some of us who actually know what that means. Alternatively, how many of you actually have or expect to have a patient suffering from neuropathy? A few more, as expected. My acquaintance with neuropathy came at the same time that I was diagnosed with HIV. I was in hospital in an acute med ward with elderly ladies who seemed to sleep or grunt, basically. And I was asked if I would like to go somewhere more private. When somebody says that to you, you know it's not going to be good. And they took me in a wheelchair because at the time, I now know, the neuropathy was giving me so much pain that I could barely walk. When I was told that I had HIV, I was very, very shocked because circumstantially I had been offered and had taken an HIV test in the sexual health clinic a few weeks before. But as you may or may not know, it takes 5-6 weeks, depending on which generation of HIV test you use, to be able to actually pick up the RNA. All I remember from the conversation that I had, well, it wasn't a conversation, all I said was, I can't die, my daughter needs me. And the sexual health nurse who was there, who became a friend, said I could live to be 100. And I just hung on to that forever afterwards. When I came out of hospital reeling with shock, I went to see a local HIV charity, but was told I might not be able to get there because there were 53 stairs. Undaunted, I went up the stairs and down the stairs on my bottom. There's always a way around things. At the same time, I saw my first ever neurologist, which was very exciting. And after establishing that the TENS system, I couldn't feel anywhere, not even at all, in my feet and lower legs. He mentioned neuropathy. I thought, nerves, it's to do with nerves, but I didn't understand anything at all. But what is it actually like? It's the ironic juxtaposition of not being able to actually feel the ground, or sometimes feel your feet even, but having a lot of very sharp and acute pain. It's very like being the Little Mermaid. If you know the story, you will know that the sea witch gave her legs so she could go and find the prince she saved from the waves. But the downside was she would always feel like she was walking on knives. And that is frequently what I feel like too, as do others with neuropathy. I also have drop foot, which is very unglamorous, and I've always felt that it sounded like a sheep that should be put down. In reality, what it means is that uneven ground, and even as happened just now, a slight slope, could send me flying because I don't feel it actually happening. I use the crutch, which has been carefully secreted somewhere down there. Yep. Cool. Means I can get back without falling it over, because I need it not to fall over. I do not need it to walk. I can walk without it. The neurologist referred me back to my GP with a happy little list of medications that may or may not help me. My GP was young. She was dedicated and probably slightly unfortunately misguided in that she gave me all of the medications in sequence, but she made me have them right up to the maximum dosage. You will all know that being small, titration would have been rather better. And I lost a year of my life going up in dose from medication to medication. I went through all the normal suspects. If you know about neuropathy, you will be very familiar with gabapentin, amitriptyline, pregabalin, and duloxetine, to name but a few, all of which were developed for other conditions, but may have benefits in deadening any nerve pain that people with neuropathy actually had. The worst thing was, you felt terrible. You felt really terrible. You felt dizzy. You got constipated. You watched soap operas. I have never previously watched soap operas, but didn't stop the pain. And that really was the whole point of them, or at least I thought it was. I ended up with codiadromol because I could control it myself. If the pain got really bad at night, I would take some. I was prescribed 8 a day. I rarely ever had more than 2. So that was how I managed it until I just got into deep breathing and whatever, which I will not go into because there is someone who can talk so much more effectively about that on the panel. But not sleeping makes your life so much worse. If any of you have sleep problems, you will understand that you feel depressed because you didn't sleep. My solution, being also a Radio 4 addict, was to listen to BBC Sounds. It's what I do now. And I listen to In Our Time. There are very many episodes up there. I thoroughly recommend it. Melvin Bragg, 15 minutes. I'm out like a light and I will never know what happened to Queen Melisande, Queen of Jerusalem, ever. And you learn all sorts of useful bits of information that you can bore people with like that. So what does work? As a lay member of a NICE committee, I was with 3 eminent, respected consultants who I liked and I respected hugely. I just joined the said committee. And we were looking at potential alternatives to the grade system, which you will all be familiar with. We were looking at the idea of using traffic lights for people who can't get their head round grade. And we looked at a meta-analysis of the benefits of medications for nerve pain. I didn't say anything about myself because I was very new, I was very self-conscious, and I didn't want to personalize it. But I really wish I had now. The meta-analysis revealed that only around 3% of patients actually benefited from the reviewed drugs, as opposed to a startling 24% from placebo. I cannot comment on the validity of the meta-analysis, but that is what it said. It was at that point that one of the consultants, a woman I really like and really respect, still do, said, well, you've got to give them something, haven't you? And I have never, ever forgotten that. And I really wish I'd said, give them something. Yeah, let them lose a year of their life. Let them be completely out of it. Let them keep cherishing that little hope that this will work. When actually it was for epilepsy, or it's an antidepressant, or whatever, because it doesn't work. I'm very much into alternative treatments, as I've been saying earlier, and acupuncture work for me, but also psychosocial treatments are becoming more accepted now. And acceptance and commitment therapy, or ACT, was trialled at the Chelsea and Westminster in the open study, which I was involved in, on the language side, making it was delivered online. So I helped with the language being accessible to the HIV patients who were signed up to it. And my life changed so much for the better when, in 2016, I was lucky enough to be referred to a pain clinic. They are few and far between, and it's a postcode lottery. For me, it was actually, I think, because people I knew spoke to people I knew, and I ended up getting there. And that is when that word, peripheral neuropathy, entered my head. But most importantly, everything was explained to me. If you're going to manage a long-term condition, you need to actually understand it. And it was just in time, because I had just started to use a wheelchair again. I said I did, on initial diagnosis in 2008. This was 2016. Because I was very wobbly, and it's scary. I used to make bad jokes about how the earth was moving for me, but clearly not for everybody else. It was like walking on a trampoline. I saw a nerve and muscle conductivity specialist who confirmed that both my lower and upper limbs were affected, which is why I was so unstable. To be medically accurate, and I quote, mild symmetrical mixed sensory motor axonal polyneuropathy of both the upper and lower limbs. You can see I'm not a medic, but it helped just to know that it was really happening, that there was actually a physical cause for this. He said, you feel as if you're being dead-legged. I did. He said the paralysis was spreading up my leg, but I should get out of that chair, use it as a walker, and then I would be able to walk again. But if I didn't do that, I would be in that chair forever. And it's not fun, If you're in a chair, people hold their bags here, yeah? And they hit you. Wherever you are, in a supermarket or a station, you're hit by somebody's bag. And they think it's your fault, which is really annoying. I used to walk around a lake near where I lived, and it took me 3 months to get round that lake. When I finally did, the man in the cafe at the end looked at the empty chair, which I was gleefully holding, and said, you lost something, love. And I said, come on, you know what I've been doing. And he said, have a cup of tea on the house. So we celebrated. Now, stigma. Pain itself is a condition that causes stigma. I have friends who are diabetic who've told me that they feel stigmatized if they explain that their neuropathy is caused by diabetes. There are others who have had chemotherapy and have chemotherapy-related neuropathy. Quite understandably, they do not want to open up the whole subject of cancer in a conversation. But believe you me, saying that your neuropathy is the result of the HIV virus is a serious conversation stopper. So I tend to sidestep by explaining what neuropathy is, that it's due to nerve damage and nerves don't regenerate, and a variety of conditions, cancer, chemotherapy, diabetes, trauma, and some viruses will cause it. And it's not that I mind saying that I'm HIV positive, it just takes the conversation to a whole different level. And because I use the crutch, I'm often asked, what have you done to yourself? By friendly ladies elderly ladies in my church. Sadly, they don't remember the answer. And I get, was it skiing? I like that question. It suggests I'm looking young and athletic. A hip replacement, which I absolutely hate because it suggests I'm looking old and decrepit. That's when I launch into the neuropathy descriptor that I've just mentioned. Some people do know that neuropathy is actually common with people who are diabetic, so I get that a lot. But how do you describe pain? You can't see pain. You actually can't measure it. There may be things with the thalamus that may come on. There's a quote that says that pain is whatever the person experiencing it says that it is. Now, apologies to those present who do this, but being asked to score pain on a scale of 1 to 10 just doesn't cut it, you know? It always brings out the worst in me, and I get very tempted to say 14. The last time, just a week ago, I was at an event staged by the PAINSTORM Collaborative in Aberdeen in the Art Gallery for British Science Week, called Expressions of Pain, which was to allow people to find ways of describing their pain. People use words, they used bits of art as examples, like something bright blue was very, very close to the pain that somebody felt, not red, which I thought was quite interesting. They worked with clay. The workshop using words was conducted by the person who did this talk last year, my friend Fiona. And she has chemotherapy-associated neuropathy, and she does workshops with other people who have suffered from the neurotoxicity of chemotherapy. I'm going to leave you with a few examples that came from that Expressions of Pain event. The experience of pain is a source of fear. If pain happens more than twice, you feel that there is a pattern-forming thing happening, and you are anticipating the trauma being repeated, which leads to fear, which can recreate pain, even when the source of trauma is removed. Intensity of pain removes the quality of life. Disability is the hardest part of pain. Pain comes at a price. How do you plan your life if pain may prevent you from doing things? Many people expressed concern that doctors just don't get it. Clinicians see patients as machines, and said there's a stark difference between the kind of things you think you need and they think you don't. But I'll leave you with the last word being given to the very eloquent Fiona herself, describing her own pain. They call it by a name I can't even spell. I call it the sharp-beaked bird that took my life away. Thank you.
Jo, thank you very much for that superb patient perspective. And I, as a neurologist, certainly fill in that part of people who, we see patients with neuropathy, but what we don't do is treat patients as a whole. Yeah. That is the problem, I think. And we can talk about this later on. So what I'd like to do first is, can I just get the panel to introduce themselves? I know you've read about them, but David, why don't you start and tell us what you do, so then we can just remind me as well who you are and what you do. All right.
Fantastic, thank you. First of all, thanks for the invitation. And thank you, Jo, for sharing your experience. My name's David. I'm now a researcher at Imperial College and the University College of Osteopathy, just having finished a PhD where I looked 3 years at clinical trial methods and non-pharmacological treatments for pain. And that really was fundamental, as you'll hear later on. There's a lot of interest now, especially because many drugs don't work for a lot of pain experiences, including neuropathic pain. But the problem in non-pharmacological pain research is really the methods. How do you study something that's complex, that involves a lot of interaction between patients and providers often involves various different components of treatment. How do you study that? So over the last 3 years, we looked how that's done, and we came together with experts in the field and with patient partners and with various stakeholders and developed 2 big frameworks for clinical methods, clinical trial methods. One of which on the pragmatic side, so if you design a trial where you compare something against treatment as usual, standard care, that involves a lot of messiness of clinical practice. So there are a few guidelines you can now follow to still ensure that you can interpret your trial. And on the other end, what's a placebo control for something like osteopathy, like a psychological intervention, like exercise? So it's just been accepted in the BMJ, which I think really shows as well how important that topic is and how big the interest is for that. We developed a framework which guides people through the concept of the control intervention all the way to how you conduct that and report that in a clinical trial. And the reason I think I was invited here is because now we've moved into actually applying that. And it's really been, I need to point that out as well, I think, or I want to, the Alan and Sheila Diamond Trust, who put us into the position to now be able to study something as complicated as a multimodal treatment for painful diabetic neuropathy in that case.
Okay, well, we'll come to the exact details, but that's great. So, you know, it is evidence that you need. It's evidence that NICE needs.
Yeah,
you know,
absolutely.
because, you know, anecdote is very good. Julian, just tell us a bit about yourself and where you come from in terms of this field of peripheral neuropathy, painful peripheral neuropathy.
I'm Julian Weiner. I'm a osteopath, 30 years in practice. I think a lot of osteopaths, anybody who deals with patients in pain, will experience somebody with peripheral neuropathy. Whether or not they've been diagnosed with peripheral neuropathy is a completely separate thing. And I suppose I have a different kind of view with pain. I think that pain is wonderfully described by Joe just now, where pain is something which each individual, whatever they say they have, 9 times out of 10. And I think we have to accept that as therapists, as doctors, as neurologists, that when somebody comes in and says, I'm in pain, probably the best thing to do is to say, let's hear about it. Let's listen to you. Explain what the pain is. Don't jump to conclusion why they've got it, how they've got it, how I'm going to get rid of it. Find out what the pain means to them. I was involved in a very bad accident 30 years ago. I was at the British School of Osteopathy. I think I can let it loose now and say that I think I told them that I was studying at my father's clinic in Rome, but I was actually skiing. And I had a very bad accident and came back to London, very messed up, posterior fracture dislocation, peculiar that one because it happens to people in an electric chair. And I was given really bad ways of treating my pain. Okay. And I had a look at other things, and I'll speak to you about it a bit later on, which is photobiomodulation, sometimes referred to as laser therapy, but it's an interesting one.
Okay, Elliot.
Yes, I'm Elliot Nation. I'm also an osteopath, although I work most of the time now in magnetic stimulation, which is a form of neuromodulation. And there are 2 types of it. So there's a transcranial version, which works directly on the brain, and there's a peripheral version, which works anywhere on the body. It's used primarily in psychiatry, but now they're finding there's a lot of other uses for it, including in the field of pain and neuropathic pain in particular. There's very good research for it, which we'll discuss a little bit later.
And Stephanie's got a video.
And we have a video from Dr. Stephanie Barrett, who I work with.
Prasan, tell us about yourself.
Hi, I'm Frank. I'm a diabetologist at King's in the diabetes unit. 1 in 3 people with diabetes suffer from some sort of pain, chronic pain, but 1 in 4 have true diabetic neuropathic pain. And actually, if you look around London, we don't have a specialist diabetic neuropathic pain clinic, but we have one at King's where I work. We set that up a few years ago. And we initially set it up to clarify the reason for the pain, not to treat it, but to understand if there's anything else complicating it to get a pure diagnosis. But of course, over the last 10 years, we've got good experience in managing it. We do multimodal therapies, but also we have access to the pain clinic, to neurology, and to many other services, psychology, for example, to help manage the pain. So through initially starting a clinic to understand what is the driver of pain, it's evolved into understanding that and into somewhat attempting to manage the pain. It's really a challenge still.
Okay.
But it's fascinating that despite pain being so ubiquitous within diabetes, there isn't in this country more than 6 dedicated clinics that do this for for the patients.
Okay, great. Anthony Ordman.
Hi, excuse me, I'm Anthony Ordman. I'm a pain doctor. Quite a few years ago I had the opportunity to go to the Royal Free Hospital in North London and set up a pain clinic from scratch and learn all the things that we've just heard from Joe, that the medicines occasionally help but so often don't, but they always cause problems.
Yep.
And nobody ever takes patients off medicines, they only put them on medicines. That you cannot just try one after the other. You had to add a few together to maximize the positive responses but minimize the side effects. And you must always gauge what effect they're having on the person. Have you actually turned the person into a zombie, in which case you have failed, because your purpose is to give them as much of their life back as possible rather than take it away, without getting them addicted to some of the medicines. I don't allow anybody in my team to call them painkillers because they do not cause pain, and calling them painkillers causes disappointment. So I could go on, but given the opportunity to set up a pain clinic, we could attend to all of those worrying thoughts, all of those misbeliefs, all of the deconditioning on the body, which I think if you attend to those non-pharmacological things, you can do as much good as with the pharmacological.
So we come back to the same topic about not just treating the painful feet, it's treating the whole person, including the brain and the psyche. Can we just have my slides back on? I don't know whether we can just move that. And I think the point that's being made is that you don't die of painful neuropathy. That's why it hasn't become a major area of investigation. So as a neurologist, we were thought about as being elephantine in our diagnostic skills, but rather murine in our therapeutic skills. This was 20 years ago. And now we've got treatments for stroke, we've got thrombolysis, we've got thrombectomies, we've got treatments for MS, which includes stem cell transplants. For heaven's sake, we're treating genetic diseases like spinal muscular atrophy and familial amyloid polyneuropathy. But the 3 big areas, as far as I'm concerned, is where we got big black holes are motor neuron disease, dementia, Alzheimer's, although that we're on the cusp there, and pain. That is where we have not made really much progress in terms of treatments. And I think what I'd like to end up with this evening is, with our panel, Joe, is to have some degree of hope and a view into the future as to where we're going with all this. Okay. You went through neuropathy the last time, so I'm not going to spend much time about peripheral neuropathy, but that's just to put that through. And you talked about not just pain from the sensory side, you talked about weakness, which is why you've got your foot drop and why you're unsteady and liable to fall, which is important. And the list of causes, there are volumes written on the causes of neuropathy. And obviously diabetes, perhaps, is obviously the most common cause worldwide, and that is increasing. And the other is HIV itself. 40 million people worldwide have HIV disease. Now, the majority is in sub-Saharan Africa, where the only medication you may, if you're lucky, get is amitriptyline. As far as the pain aspects are concerned, you described your pain wonderfully. These are the sort of pins and needles, the sensitivity to light touch, sleeping with your feet sticking out on the duvet because they're so uncomfortable with anything light touching. And perhaps you've talked about the number of patients, 415 million patients worldwide with diabetes. In the UK, you've got 4 million, and a quarter of those will have a painful sensory neuropathy. And the problem with all the drugs is that you'll get 50% reduction in 50% of cases. That's the bottom line with whatever drug you're using. And so I'll be interested to see what the other treatments have to offer and which way we're going for the future, because I think we have to have some hope in terms of where we're going in the future. The global diseases of burden studies really lists all the causes of morbidity and mortality worldwide. And if you look at this chart, you've got heart disease, stroke, you've got diabetes at number 8, you've got migraine at number 15, but nowhere do you have peripheral neuropathy in terms of quality of life, in terms of how it affects worldwide the number of patients. And I think that is an error, partly due to us in terms of not focusing it, because you don't die of neuropathy. Okay, you focus on the heart, you focus on the strokes, but not the quality of life. And this is the same worldwide. It's the same all over the world. Peripheral neuropathy and neuropathic pain comes nowhere in the global disease of burden studies. And I think that is something which needs to be remedied. These are the medications you talked about. You know, this is the list that I use when I see patients in my clinic. And the other thing which has come on, and it may be relevant here, is that we're seeing more and more patients who've had COVID. And they're presenting with painful neuropathy, small fiber type symptoms. Now, some people are being labeled as being functional, but I think it's all truly organic. The problem is we don't know the mechanisms of what's causing this. And one can be rather dismissive just because we don't know what the cause is. And just to finish, I will read you about a patient I saw last week, 51-year-old lady. She had COVID, PCR positive, then aware of burning pains in her buttocks, thighs, and by July, this had spread to her eyes, ears, and face. She was unable to go to work, and she had pregabalin, gabapentin, duloxetine. She couldn't, she became dizzy with gabapentin, and she wanted me to give her intravenous immunoglobulin. Now, you may know what intravenous immunoglobulin is. It's a blood product which is used for various types of neurological diseases. It costs about £5,000 for a 5-day session, and NHS England strictly governs the use of it, quite rightly. And it is not, we cannot use it for small fiber neuropathy, full stop. And so she was stuck in terms of her quality of life, in terms of where she was going. And these are the sort of patients that we see in our clinic. And in the end, I think one has to go into a multidisciplinary pain clinic to be able to manage these sort of symptoms in patients. And Anthony and I have known each other for quite a while, because the good thing is I would send patients to Anthony and they never come back to me because they've been managed very well by him. Okay, well, you know, that's just the introduction, I think. And so I think what I'd like to do first, Joe, you described very well your experience of the medical systems of neurologists. And I was interested when you described your nerve conduction studies, it was labeled as being a mild axonal neuropathy. You didn't make any comment on that, because for you, obviously, it was not mild.
No, but the fact that it was diagnosed at all was an enormous relief, because people can't see pain, neither can they see weakness.
Yeah.
And it was the not seeing weakness that I was finding particularly challenging, because I could stand up. And so people would say, well, you can stand up, why can't you walk? And hence me coming up, I'm a wordsmith, with I'm walking on a trampoline, the earth's moving for me, but not for you. But it was very scary. I really found it very difficult to walk. Also, in my experience of people living with HIV, I had seen people who were on the neurotoxic earlier drugs, so a different situation to me altogether.
So just talk about the earlier medications for HIV disease, so that's DDI, DDC, D4T, which themselves cause a neuropathy, on top of the neuropathy the patients had from HIV. But, you know, it's prolonged their lives, you know, so there was, you know, it was a double-edged sword. But they're not used anymore, but they are used in Africa because they're cheap.
Yeah, they are. But anyway. I had no drugs. In fact, because I'm an elite controller, which happens to mean, I love the word elite, but it happens to mean that your body gets rid of the HIV virus by itself. And I had no sign of the virus from diagnosis in 2008. About 6 months later, it was not registered at all in blood tests until 2018, when a tiny amount showed again. Right, okay. So I know that my neuropathy is because of how my immune system was affected, not because of medication
Okay.
and a reaction to it.
So just to start off with, Anthony, do you just want to comment on where we are at the moment with neuropathic pain medications, i.e. that list? And then we'll move on to the panel, because I think then we'll talk about research from each individual member of the panel in terms of what research are involved, what the data, what the evidence is, and where we go to next, really. So Anthony, just tell us about what's available now. Okay.
Well, I suppose we could start with your list and say that if any of these was really, really good, you wouldn't need such a long list of
Correct.
treatments.
Yeah.
And I think in any patient who comes to see me, the starting place is the patient. What have you tried already? And what would suit you? For example, a really elderly person, you would not start with the standard drug amitriptyline because you will erase their memory for them, and you don't want to do that. So we're almost picking medicines that you take by mouth according to their side effect profile and keeping the patient safe, rather than there are specific medicines for specific pains. I think the conventional drugs that everybody knows the names of, amitriptyline, gabapentin, you wonder sometimes how they got a license to be appropriate for these medicines.
Because they were all prescribed for epilepsy, they were prescribed for epilepsy and depression.
Exactly. Yeah. So you've got to go very carefully. I tend to then go on to secondary medications like carbamazepine, or preferably oxcarbazepine, that's less sedating. You will always go for something that can be applied topically if possible, because you don't get the side effects.
Fentanyl.
So capsaicin, maybe local anesthetics, maybe intravenous infusions can be useful. But as far as medicines are concerned, we are in a hard place. We do not have good medicines that work reliably.
That's why the neurologist sent Joss off with this list of drugs and saying, okay, off you go, give it a go, and otherwise get on with your life. That's the scenario.
But also with the side effect profile you've just mentioned, I feel really angry that I did lose a year of my life, because this poor little GP, she was very keen, was literally taking me to the maximum and said, you have to do this. I can't give you anything else until you have gone to the maximum dosage. And I'm weak.
Yes, we wonder who draws up these protocols and for what reasons.
Okay, good. Well, let's just talk about the research and which way things are going. We've set the background as to where we are, which is not a good place in more ways than one, really. So, Dr. Bhatt, why don't you tell us about, again, still with drug aspects, you've published papers on diabetic neuropathy and trials of combination therapies. Do you want to just take us through a little bit about your experience and where we are with combination medications?
Well,
taking into account the side effect profile is hugely important.
Joe, that's absolutely, Hadi and Joe, we struggle too. I mean, in our clinic, when we start our medications, there is no simple way of choosing which one to start. It's kind of a hit and miss. Yeah, we try and tailor it according to their needs. Pregabalin sometimes, if you're more anxious, tend to use pregabalin. If you're more, upset and depressed about it, one could try duloxetine. In diabetes, we've long sort of avoided using amitriptyline because it's considered a dirty drug and you really don't want to use it. So the second stage has been, the level 2 of these treatment augmentation. A is very difficult to do. So when we looked at our audit of patients referred to our unit, the GPs would have gone through 1 or 2 drugs. They would have had side effects and completely stopped them. At point of referral to us, the average pain duration was at 2.5 years, and about 30% weren't on any medication, but would have tried something at some point of time. So huge challenges getting off the ground. And then there is this dual agent treatment. Now, we've had a big study published recently. It's called the Option DM study. It's published in the Lancet. But it had a very simple premise. The premise being, which of the first 3 agents is the best first choice? It came from one of the main sort of applicant being on a NICE committee and going through questions about cost about 10 years ago. So which of them is the first agent, best agent? So amitriptyline, pregabalin and duloxetine. And the headline answer was that all three of them, when used, seem to be equally efficacious as a first-line agent. We used the pain rating score that you don't like, because that seems to be the only sort of simple score available. And we used to ask people to rate it on a 0 to 10. So we asked this every day for a year. But it was like a Top Gear kind of study where, you know, three people get into 3 cars, drive them for a week, and get into another car, drive it for a week. That sort of.
Yeah.
So we had a crossover at some point of time. But we found something interesting. If you combined and they had a combination arm, if pain wasn't controlled enough, what we found was that on a single agent, only 40% achieved a pain score of 50%. On a dual agent, another 18 to 20% benefit. And this is perhaps the first study which was sort of powered enough to look at dual agents. The other thing we found, and a good signal that needs to be worked out a little bit more, but it probably, in your experience, is already validated, is we didn't have to crank up each of the agents to full dose. Cranking up the agents to full dose gives side effects. So dual agents, but neither of them fully cranked up, gave a better response, was more comfortable for the individuals that were in the study. So the sort of thought process moving forward is that you don't have to crank pregabalin to 600 till you're a zombie. If it doesn't work at 300, it's not going to make a difference at 600. Start thinking of a bolt-on to that. But there is emerging thought that drugs is not going to be enough, and that we may need more than a multimodal therapy. So we've just recently, this week, started on an NIHR-funded study using non-invasive neuromodulation, in this case electrical stimulation, called FREMS. It's a Italian sort of device. It's like TENS, but this is more frequency modulated. TENS being me just talking like this, and that is, it sends the same frequency all the time. FREMS is like me saying the same thing in a singing sort of way. So you have high notes, low notes, a pause in between. And we've just started, we've received a good grant
Elliot,
to do
this
that.
is something you're involved with as well, but before we come to that, I mean, one of the questions, why do some people get painful neuropathy and others don't? Obviously there is some sort of genetic aspect to this. Why do some people respond and why do some people not? You know, I think that is a big question in terms of mechanisms and underlying genetic predispositions. Maybe now we're going to talk about the future treatments. Should we have a look at the video, please? Stephanie Barrett's video. Stephanie is a well-known rheumatologist. She was president of the rheumatology section of the RSM previously. And then Elliot, who works closely with her, will take questions and we can ask him about that, really. So should we have a look at the video that Stephanie's made, please?
Good evening, everyone. And I'm so sorry I can't be there in person, but I would love to have been there. Unfortunately, we're stuck in Johannesburg. There's been industrial action. We can't go anywhere for another 24 hours. Still, it's very good to be able to deliver some good news about chronic pain. So I'm Dr. Stephanie Barrett, consultant rheumatologist at the London Clinic, and I'm a past president of the rheumatology section of the Royal Society of Medicine. I am so delighted to say that things have turned around since the last conference here about painful peripheral neuropathy. So there has been a large study of patients using neuromodulation, and the results are very encouraging. Elliot will go into that in much more detail. I will tell you a little bit about RTMS and how we've been using it. So it's a very safe, non-invasive brain stimulation technique that involves the use of a magnetic coil, which also delivers a series of rapid magnetic pulses to a specific brain area. In the context of chronic pain, RTMS has been shown to be effective in reducing pain intensity and improving quality of life in pain sufferers. It has been approved by the FDA and NICE for the treatment of depression and OCD, and we are hoping to apply to NICE to asked them to prove it for pain. We started to use this technique of neuromodulation for pain 5 years ago in collaboration with the RTMS Psychiatric Centre in Harley Street. I sent my patients with chronic pain to the psychiatric centre. They also had depression, but what was notable was the pain improved dramatically after 20 sessions of low frequency stimulation to the right dorsolateral prefrontal cortex. People who'd suffered from widespread body pain for years, for the first time, had a means to switch off their miserable daily pain using this non-drug, non-invasive and safe tool of RTMS. In 2020, Tanwa et al. Studied 90 patients with severe fibromyalgia, severe body pain. Randomizing into sham and RTMS groups, there was a significant improvement in the real RTMS group with pain relief lasting at least 6 months. That was as far as they studied the patients to. It possibly went on longer than that. At that point, I began to set up the RTMS and PMS treatment centre at the London Clinic, and we've been able to pioneer RTMS and peripheral magnetic stimulation at 116 Harley Street. Since then, we've treated and studied in detail more than 15 patients with 20 sessions of RTMS, and we've had remarkable breakthroughs. Elias will speak much more about this in his talk. So we've had, for instance, corporate lawyers who've been signed off for a year or more, and they've been able to go back to work full time. We've had mothers and grandmothers who have been unable to look after their children and their grandchildren. They've been able to go back to their activities and be part of their families. The upside of this is so enormous, to see people going back to where they were before they had the illness. So the other benefits of RTMS that we have found are relief from exhaustion, severe fatigue, sleep disturbance and brain fog. The mechanism by which RTMS works to reduce chronic pain is by modulation of pain processing in the brain. The magnetic pulses are delivered by the RTMS coil after the activity and altering the activity of the neurons in the brain, leading to changes in a way that pain signals are processed and perceived. The magnetic fields produced by the RTMS penetrate the scalp and skull to reach the brain, where they induce small electric currents in the specific target areas which are involved in pain processing. These include the primary sensory cortex, somatosensory cortex, the dorsal anterior cingulate cortex, and the insula. By applying repetitive magnetic pulses to these areas, RTMS can modulate the activity of neurons and of the function of neural networks involved in pain perception and modulation. They normalize abnormal pain processing and reduce pain sensitivity, and also they enhance the brain's natural inhibitory processes, which were present before the chronic pain kicked in. The brain also becomes much more plastic and able to build more healthy, non-chronic, amplified pain pathways. Moreover, RTMS can also modulate the release of neurotransmitters such as endogenous opioids, which can have analgesic effects. Several studies have investigated the use of RTMS for chronic pain, including neuropathic pain. A large diabetic study showed improvement, and several other studies which Elliot will go through in more detail. So in summary, RTMS has been shown to be very effective in reducing pain intensity and improving quality of life in individuals with fibromyalgia, neuropathic pain, and several other pain syndromes which previously have not responded to medication, physiotherapy, etc. So what we have become experts in addition to the RTMS, is the peripheral magnetic stimulation. So we've set this up. We're the only centre in the UK using peripheral magnetic stimulation for rheumatology patients. Both Elliot and I worked with the University of Maastricht, and we are going to set up courses in PMS in the future to train other individuals. So the PMS works to relieve pain in peripheral neuropathy. It's not fully understood. However, it is thought that the electrical impulses produced by the PMS can interfere with the transmission of pain signals along the afferent nerves, thereby reducing the sensation of pain. PMS may also modulate the activity of certain regions in the brain involved in pain processing, such as the thalamus and the primary somatosensory cortex. By modulating the activity of these regions, peripheral magnetic stimulation reduces the perception of pain. And this is what we didn't know before, that the peripheral application of the coil could affect brain activity. So this has been shown on PET CT scans in using PMS and RTMS. A study published in the European Journal of Pain in 2019 used PET CT scans to investigate changes of brain activity in patients with peripheral neuropathy. They underwent peripheral magnetic stimulation treatment, and the study found that the PMS led to changes in brain activity and pain processing, particularly in the thalamus and the insula. A further study in pain in 2020 used PET CT scans to investigate changes of brain activity in patients with fibromyalgia who underwent RTMS treatment. The study found that TMS led to changes in brain activity in regions involved in the pain processing, such as the thalamus and the prefrontal cortex. So, on to functional MRI studies. A study in the Journal of Pain, 2012, found that RTMS in neuropathic patients led to changes in brain activity in regions involved in pain processing, such as the primary somatosensory cortex and the anterior cingulate cortex. A study in pain in 2015 used functional MRI to investigate changes in brain activity in patients with chronic pain who underwent PMS treatment. The study found that the PMS treated patients led to brain activity in the regions involved in pain, such as the thalamus and the insula. A further study in 2018 used functional MRI to investigate brain changes in patients with fibromyalgia who underwent RTMS treatment. The results were very encouraging, and a significant number recovered from their pain. It was also noted that the RTMS led to changes in brain activity in the areas of pain processing, such as the thalamus and anterior cingulate cortex. So we have good science showing that the RTMS hits the right areas, and we now have some excellent studies showing that it works in practice. So both RTMS, which is the application of the coil to the skull and to the brain, does have a significant effect in patients with painful peripheral neuropathy. Well, this is an absolute breakthrough. We've been using the peripheral magnetic stimulation to treat people with the peripheral neurological pain as well. So we're going to take this forward, do more studies, approach NICE, and offer this service to people who are now suffering from this terrible condition. So I hope that gave you some background to what we've been doing, why we use TMS, why we believe in it so much. And I'm also very grateful to have Elliot at the meeting with you tonight. And Elliot Nation is the TMS osteopath, and he's done marvellous things with our patients, and he'll explain much more about how things work. So thank you very much for listening. All the best.
Thank you very much. So that was a very detailed account of magnetic stimulation peripherally and centrally. So Elliot, do you want to just first of all explain what is it that you, I mean, is it painful? I mean, I've tried magnetic stimulation. You get this great big thump on your head. I mean, how uncomfortable is it to do these things?
Well,
do you want to explain what actually happens? Because you hold this ring over your head and you go
I've
bang.
got a couple of pictures actually.
Okay, why don't you come up and take
that
us
was,
through that? Yeah.
Because it does sound scary. Neuromodulation.
Yeah, they're fiddling with your brain. You know, I mean,
it sounds scary, but the majority of patients say it's painless. I've actually had people fall asleep during the treatment, so it can't be that bad. Which is obviously one of the
okay, well, let's go.
benefits of it.
Should we go through a couple of Elliot's slides?
Yeah, lovely.
If you've got some there. While the slides are coming on, one key question is, you know, you give them magnetic stimulation, you improve their depression rather than the painful aspects. I mean, what's the evidence that you're not just dealing with the mood aspects and you're actually dealing with the primary pain aspects?
Yeah, so it has a sort of...
well, take us through this first.
That's okay. There's strong evidence for it in psychiatry. It's used for depression. But the area of the brain that's targeted is different for pain than it is for depression. So what they find in chronic pain, particularly neuropathic pain, is that the motor cortex actually shrinks in size. You get this reduced connection essentially between the painful part of the body and the area of the brain associated with it. So we actually target that brain with a protocol that increases the activity, and with repeated sessions it's actually been shown to increase neuroplasticity within the area, which means that area of the brain can remodel. And actually there's been some fascinating studies that have shown increases in cortical volume in the areas that are stimulated over time, which
so
they think is
what actually happens?
Effect.
I mean, take us through this patient's journey.
Yeah, so for depression, it's used for treatment-resistant depression. So these are usually people who have already tried all of the medications, none of them have worked, and then they get given this as a last resort.
Yeah,
so
I think it's now an alternative to ECT, which, you know...
Yeah, exactly. It's certainly a lot less aggressive than that.
Who had to undergo through this. So it is an alternative to ECT for depression.
For pain at the moment, it's on the NICE guidelines as a recommendation for further research.
Okay.
But since that recommendation was made, there have been, I counted 10 systematic reviews and 2 meta-analyses, which are the highest order of evidence showing that it's effective for pain.
Okay.
So we're hoping that NICE will...
So it sounds if all you need to do is give them magnetic stimulation peripherally and centrally. You know, you combine the two, and you're home and dry, really, aren't you?
We have been finding it very effective for that. As with any, I mean, this is in its sort of relatively early stages.
I understand.
The effectiveness is being improved all the time. There's some fascinating research, a lot of it coming out of the University of Maastricht, on ways to make it even more effective. And some studies from America, a Stanford trial last year, for depression, had about 85% remission rate in their study, which is remarkable for something that's medication-free and pain-free.
Can I just bring David into this? How do you do a sham trial with magnetic stimulation? I mean, you know, that is the key question, because that's what NICE is going to want.
Random control
trials to show that it's effective. How can Elliot do that? Or
interestingly, they don't always want that. So you can get on recommendations from various different types of comparisons. So comparing it against something that's currently used as best practice, for example, which we know doesn't work particularly well. The question of how that feels to the patient, I think, is fundamental to the question of can you actually design a good sham control for this? Because if it feels considerably different, there is that risk of what you call group contamination. So people in one arm really expecting to get better. And if we expect to get better and expect some benefit, that is really what feeds the placebo effect, and you can then feel better. You're more likely to get better.
Yeah.
And there are a lot of other contextual factors around that. So, I hate to be a bit of a downer here, but new treatments, when they first come out, do tend to show good effects.
Yeah.
And then with new drugs, with spinal cord stimulation, endocannabinoids, that tends to wean off. The better the studies get, the less excited people get about it.
Okay.
So
maybe you
from
guys
a
need
research
to
point
get
of view,
together and work out a system.
Yeah, that's it. It's a very exciting area that there's a huge amount of potential in.
Excellent.
But it's certainly not fully there yet.
Well, it's the first I've heard of this, so I think it is certainly.
I just want to ask, how long is each session?
So typically each session is about 20 to 30 minutes. One of the big problems with it historically has been the feasibility, because a traditional RTMS treatment would consist of 20 to 30 sessions delivered once per day. So you have to get somebody in 6 weeks in a row, you know, which is unrealistic.
And you've got to have the technicians as well, and then
exactly.
you
But
know, there's the whole other question about private medicine compared to NHS, because I mean, 10% of people will afford this sort of treatment.
yeah, exactly.
90% it will be on their accessibility. So I think that is something we can perhaps discuss in questions. Really.
Yeah, just on that point, there have been some really interesting new studies on what they call accelerated protocols. So now they're delivering up to 10 sessions a day and getting that entire treatment done in a few days of treatment rather than spread across 6 weeks, which makes it a lot more realistic. There's also a new type of treatment which does exactly the same thing, but it stimulates in a different way, and the sessions can be 3 minutes rather than 30 minutes. So
there is
there's
new progress there.
A lot of progress to make it more accessible.
Great, thanks very much, Sheila. Julian, let's come to you. So you've been involved with pain in a variety of different areas. Just focus a little bit on the peripheral neuropathic pains that you've been experiencing with. And
I think, firstly, just before I start, I just want to echo what Linda said about Sheila Diamond. This was an extraordinary woman, very humble. You would never meet a kinder person. So I think there are hundreds of thousands of people out there in the world, whether it's an ambulance here or a library somewhere else, who benefited from her philanthropy. And just before I start, I wanted to really add my absolute thanks to her. I never did a study with her, but she always gave me a really nice little Ryvita with cheese when I used to go and visit Alan. So she was
the little things that
very,
count
very,
in life.
the small things in life. I'm not sure whether you have access to the slides that I gave over there, but later on I want to show. I see patients generally with pain. Osteopaths generally see patients with pain. Somebody comes in, very few people come and say, and you ask, what's wrong? Nothing. They'll say, it's my shoulder, my knee, my back, whatever. The interesting thing about peripheral neuropathy is that you will have a few patients who will come in and say, I've got a peripheral neuropathy. They tend to be people who are diabetics and have been diagnosed with a uncomfortable, strange sensation, pain, feeling like they're going to wobble the whole time, they can't walk, and things that Joe said. And I suppose when you look at most people in pain, any therapist, whether you're a doctor, physiotherapist, osteopath, your primary concern is, can I help them? Peripheral neuropathy tends to be one of those things that you end up having to deal with the aftermath. So you do deal with the aftermath of patients who've been given the wrong medication and have then fallen and got a frozen shoulder, which may not be very significant to neurologists, but to the patient, that frozen shoulder is bloody awful. I have found that the vast majority of patients who come to see me with a peripheral neuropathy, which I admittedly will say tends to be diabetic in nature because it's the most common cause, but as I was saying to Joe, there are people with post-viral infections, CMV, Epstein-Barr. All of these can later on create a condition which can be labelled under peripheral neuropathy. Manually, there's very few things. I think Elliot will say, as an osteopath, we've got a very eminent osteopath here as well. There's not much you can do rather than make people feel comfortable. But really, are you going to change anything? Can you change how it's going to feel tomorrow or the next day? I don't think that manual therapies are necessarily ineffectual, because I think there is something about putting your hands on a patient and moving, you know, which is
yeah, no, I think you're right about the bonding of patient-doctor relationship,
it's a very
laying on of
bonding
hands,
thing.
and giving them time.
Yeah.
You know, because what we don't have in our clinics is time to deal with every aspect of that person.
I think working privately, we're probably spoilt in that I have my appointment sessions are an hour. So in an hour, generally, as well as seeing a lot of the patient.
Yeah.
So, you know, we ask them quite often to undress down to their underwear, and you're able to see, oh my God, what's that there on there? What's that there? So you're picking up things that maybe the patient hasn't seen or the patient wants you to see as well. Now, I work as an osteopath. After my injury, I was treated by somebody who had a laser. In all honesty, he didn't really understand which end to hold it at or where to use it, but he treated me with it, and something happened. I felt a bit better. So I went away and I've studied this, and photobiomodulation is really the term that we should be using. It shouldn't be called laser or LED therapy, because really what you're doing is you're photobiomodulating. Photons, what's really interesting, Nathan, is that this is another part of the electromagnetic spectrum. And here we are in 2023, not talking about some incredible injection or some incredible tablet. We're talking about light and magnetism. Now, really, you could pretty much go back to the books written about medicine in the 17th century. Maybe they didn't understand what magnetism was, or they called it some kind of humor, but they definitely understood that the natural world had ways of repairing. Now, photons, which are very discrete energy packets of electromagnetic radiation, which actually isn't too far away from what we're talking about. I wonder if we can get one of the slides up, because I just wanted to show the mechanism by which this works. It's about 3 slides in, photochemical mechanism.
That's my slide, but we can use that later.
Right. Anyway, what I was about to say is that light in very specific wavelengths, vis or visible light, as we've got these lights up here, they might have 30, 40 watts. Some of them are LEDs, there'll be less, some of them are more powerful. When we're talking about these photobiomodulatory machines, they're very low powered, 1 watt, 2 watts, but it's over a very small area. And you're using light within either the red or the near infrared spectrum. So between about 660 nanometers and about 950-ish nanometers, which is towards the infrared spectrum. These photons are absorbed by the mitochondria and the cell membranes by something which we now understand is through cytochrome C oxidase. And you get something called a singlet oxygen, which is produced inside the cells, changes the cell permeability, and you get something quite incredible happening. You get ATP synthesized, which is a cellular fuel. Now, this isn't where it ends. You can get an increase in cell metabolism, DNA production. There are loads of growth hormones and gene transcripts that can be changed by light. And we know this, and I'm not going to, anybody who wants to know these studies, pbmclinic@yahoo.co.uk, that's Papa Bravo Mike Clinic @yahoo.co.uk, which, by the way, shows you how old it's been going, 30 years. A lot of the studies that was being mentioned there, 2012, 2009, these aren't new things.
Julian, do you want to just talk about what the technique is for somebody like Jo?
Sure.
Say she has a peripheral neuropathy, she comes in, what are you going to do her? What
well,
is
the first thing I do is I look at
equipment?
what is going to help this person the most.
Yeah.
So if somebody has quite a lot of muscle atrophy with it, then really a very sensible thing to do would be to look at how you can best support that atrophy, whether it's by treating it with a handheld device, which tend to be a little bit more powerful, or treating it with a more kind of canopy device, which would allow more energy to go in over a longer period of time.
So what, you should be lying on a bed and
lying on a couch.
And then what? There's a sort of canopy. Have you got a slide of these things?
Go forwards a bit more.
I still want to picture exactly what is it that's happening with.
They're either handheld devices,
right, okay.
or they can be a canopy device.
Yeah.
And you're either going to have direct contact with the area, which I use with things like diabetic ulcers, or you can have a more kind of blunderbuss treatment, which in RTMS, I actually work with people using it with Alzheimer's, and what you said was a major issue, is that you had to come back 16, 17 times, it's a fortune, and come to London for that amount of time might be quite difficult as well. So photobiomodulation can be administered very safely with almost no side effects, unless you've got a lunatic who's going to point it directly in your eyes. And even then it would have to be absolutely focused in your retina with a laser. quite often now, some of these units are now using LEDs rather than lasers. And there's a little bit of snobbery inside the PBM community that, you know, well, I work with lasers and I work with LEDs. Actually, it's the same thing.
Okay.
Coherency doesn't really matter once you hit the skin. Not
Right.
really
Okay.
that much. You might reduce some of the penetration, but the interesting thing, and this is one of the real fascinating things about laser therapy, or PBM, is that the quaternary effect of this is that actually tissue, if I'm lasering somebody's carpal tunnel, we've actually found through these kind of specialized small protein molecules that carry the laser therapy in the bloodstream, in the lymph, that you'll get an effect elsewhere. There was an incredible study where they took some blood from some rats, and one group of rats' blood they lasered, the other group they didn't. They then re-injected this blood back into the rats, and then wounded the rats, which is quite cruel, and then counted back to see how quickly the repair went.
Okay.
And the repair in the laser group was much faster, very significant study. But those actual wounds on the rats had never been touched with a light, which is quite amazing, because we realize now that it's not just this direct,
It's more systemic effect.
there's just systemic
Okay.
effect as well.
Great.
Yeah.
All right, David, over to you.
Yeah.
Just tell us about your research and which way things are going.
Okay.
So we've got the photo biomodulation, we've got the neuromodulation, we've got the drugs, combinations, and we'll come to Anthony at the end to talk about other methods of managing neuropathic pain. So just tell us about your research and which direction that's going in.
Yeah, thank you. Can we maybe get, I think it should be slide 6, has a long flow chart on it. I think that's the only one we want to use.
So this is drug-free treatment for painful neuropathy.
Yes, so the idea really started off with patients, and it involved, for example, anecdotal reports from people with painful HIV-related neuropathies, regularly seeking out some of the community clinics at the University College of Osteopathy, one of them at the Royal Free as well, and for some reason coming back and finding some form of benefit within this. If you just go through to the one more. But I think, like Julian just said, you know, this is not going to be a silver bullet. So we are now at the beginning of a research program that seeks to integrate a number of non-pharmacological interventions and basically equip osteopaths. We're using osteopaths in this case, but I think it could be physiotherapists, chiropractors, other allied health professionals as well, to train them to work safely in particular, but hopefully at some point as well effectively with people with painful diabetic neuropathy. And part of that involves being able to triage people appropriately to see what is within your scope of practice and what do you need to refer on to a medical, to a doctor, but also in the best practice of complication management, diabetes in particular, and understanding the experience of people and how you can help them, what you shouldn't be doing potentially. So if you click a little bit further, we explored the problem. We asked people with painful diabetic neuropathy what it is like to live with that, and it really echoes Joe's experiences. And one of the people is involved throughout the study. Her name is Liz. She was super insightful and helpful in guiding all of this research. And I think that's really fundamental to doing these kind of programs, to really see what's the need there, what's acceptable to people, what do they want, what do they need, what change is important to them as well. It's not always pain reduction. For her, for example, you know, being able to have a good night's sleep makes a huge difference, even if it's just one night. And so the cost-benefit analysis for these people is very individual and changes. So it's important to incorporate that. And then the next step is to put together a working group. And we had a patient partner, but we also have neurologists, diabetes nurse, psychologists, a couple of exercise specialists and academics in pain research, neurology, etc. So you've got a group of about 17 individuals working on this multimodal treatment. And then I reviewed the evidence, and I think that's kind of interesting to ask, okay, what are you going to put into that package? What treatments are you going to include? And you know, quite rightly, there's very little evidence, no good studies really on manual therapy, which is a reason why we need to explore that and why we want to lead up to a larger clinical trial that can answer the question, does adding manual therapy to a package like this do anything? The other components are psychologically informed communication techniques and skills training. Exercise, there's a relatively good body of evidence to say that at least balance or some functional parameters get improved from regularly exercising. And of course, because we're working with people with diabetes, for diabetes management, that's an important factor, to stay active. So we're incorporating that. Hopefully, the manual therapy potentially can improve pain for a very short period of time, but maybe the combination might enable people to be more proactive, to look at experience their pain differently. And then we're going now into a feasibility study, so we're asking, can we compare this multimodal treatment with a control treatment? Are people happy to be recruited into that study? Can we deliver that? Can we measure the outcomes? And then we reevaluate. Is that a useful thing to take forward, or do we need to modify the treatment? Do we need to modify our theory of why this might work or why it might not work? What are we going to measure in a clinical trial? And then hopefully we can take that in a year or two to a larger funder and fund a fully powered clinical trial on this.
Okay, great.
That's where we are.
Okay, and then finally, Anthony, why don't you just tell us about your experience with cannabis and cannabinoid treatments, because that's obviously the new kid on the block in terms of management of pain, and you're quite experienced with it, so tell us about that.
Yeah, well, thank you, Hadi. I left the NHS about 5 years ago really dissatisfied with the medicines that we have available, as we've all discussed today. Incidentally, there was a low light laser there. Kept disappearing at weekends because staff took it home to treat themselves.
To treat their
yeah. But then 4 years ago, the regulations in this country were changed to make it possible to prescribe cannabinoids medically for carefully selected cases. And this was very interesting, and I'm going to make a distinction between joints, which consist of a bit of cannabis, some paper, some tobacco, and some insecticides and things, and they're mostly THC, and proper pharmaceutical pure preparations, just like any other medications, and these are recognised by the MHRA as proper medical products. So I got very interested in trying to use those. And so the aim is not what you do on Saturday night at a party. It is to reduce pain as much as possible, never making anybody high, never making anybody stuporous. But there are enough different chemicals in the cannabinoid medicines to try and dial up design a drug for each individual. So you'll hit the neuropathic pain with THC, which is the main active ingredient, as hard as you feel you can for that person. And you'll start low and then build up. You'll balance the THC with CBD, which isn't really, it comes from the plant, but it's not there in joints very much. So you'll tame the THC that makes you high with CBD. So you'll only lift the mood if you think the person's depressed. And then you can dial in other substances as well that may be relaxing a person if they're a bit overwrought and so on. Those are the terpenes that give the cannabis medicine characteristic smells. So it's a sort of designer set of medicines which are pure and which are very flexible in their use, which do far less harm than that dreaded gabapentin that I keep going on about. And they are not addictive, like that gabapentin that I keep going on about, and so on and so on. Now, this is mostly in the private sector at the moment, but we're beginning to work with GPs in a way that there are 1 or 2 cannabinoid mixtures that are available on the NHS. If we can make a good case that it has helped this person, it may then be prescribable.
But that's not is that the Sativex, which is used in MS patients for spasticity and
that's
things,
right.
Yeah?
But occasionally you can get the CCGs, the commissioning groups, to pay for it for pain and so on.
And just a question, how are you delivering the cannabinoids combinations?
So very often we can deliver it as an oil that is dropped under the tongue in quite precise amounts 3 times a day. Some people will have a daytime oil and a nighttime oil if sleep is a problem, and it often is with pain. If people need higher doses, they can either inhale vaporized cannabis oil through a thing that's a bit like a tobacco vape.
Well, like a shisha pipe or something.
Well, it's not quite as exciting there, but I'll discuss that with you later. But you know, there are tiny little, very discreet vapes that you can do.
Okay.
And occasionally, people prefer to vaporize the dried cannabis flower, which we can also do. So going from oils to vaporizers, we're escalating the dose according to somebody's genetic need. I think different people have genetic needs. And often when you're treating a neuropathic pain, the person will say, I don't seem to have had a migraine in the last few months, because there are very specific ways that the cannabinoids settle migraine attacks before they happen. And then one fellow said, you know, I never got any qualifications at school because I had ADHD, but I'm going back to adult education classes now. So, yeah, here I am selling snake oil. Actually, I'm not. But what we think we're doing is topping up deficiencies in the body's endocannabinoid system, which incidentally was discovered about 30 years ago by Raphael Mechoulam, who very sadly died last week. And he spoke to us at a cannabis medicine here via the video link. So there's an exciting new area of medicine which actually is cleaner and causes less dependency than the medicines we've had conventionally available. So I think there's some very exciting modalities, and this is another of them.
Well, what about the CBD you get from Holland and Barrett? Most patients have tried that.
And Amazon.
And Amazon, yeah.
Yeah.
You get anything from Amazon, all right?
Yeah. Well, I had 2 or 3 patients who you give them THC, a little bit of THC to start off with, and the CBD, and they get better. And one delightful elderly lady with arthritic pain was so much better that she could knit again, but she said, there's only one problem. My friends tell me I'm talking too much. And I don't quite feel myself. So I said, okay, let's just stop the THC. Let's give you CBD oil only, but pharmaceutical grade, so we know what's in there. And she's carried on for several years now on CBD oil alone, and she's still knitting. So yes, there is a role for that, but I would rather it as a pharmaceutical
The combination drug. Okay.
I think it's really
Julian.
interesting that all of these new ideas do come down to a bottom line, which is because they're generally smaller industries, aside from the pharmaceutical companies who can afford very, very large trials, it is difficult sometimes to, you know, when a patient comes in, I don't want to just give them PBM. I don't want to just give them osteopathy. I want to give them the best treatment. And sometimes the best treatment might include some CBD, some THC, some PMS. And it's very important, I think, as therapists that we don't get railroaded into panaceas, silver bullets. This is where we fail. If one of the greatest gifts of being an osteopath, the word holistic, when I was a kid, if you said it, I mean, you might as well make a different noise from a different orifice because people didn't like that word. It was a very mamby-pamby, used by all different kind of people. But true holism is beautiful. That's understanding that systems have subsystems, and small changes can have huge effects. What effects, as you were saying, Joe, just very small things, a small change, whether you can sleep, whether you can go to bed without your feet being painful. That in itself is a very large, and it is difficult to create a trial where you're going to be looking at those kind of very small.
So where we're going with is really multimodal therapies. Well, let's bring another multimodal therapy. I met Robert Browning having tea. Patrick, sorry. He has another specialty, which I'd never really thought about, which may play into this also. Do you just tell us about your expertise?
I'm a clinical hypnotherapist.
Should we get a microphone, actually? Sorry. Since we're talking about multimodal therapies, let's add on another one.
Yes, I'm a clinical hypnotherapist. I've been practicing for nearly 20 years now. I see people at Paul's Cancer Support Centre in Battersea, but I'm not necessarily seeing them for pain. I'm seeing them for whatever their needs happen to be at the moment. So what I'm using with hypnosis is I'm helping them to develop self-help techniques and also using the power of the unconscious mind, which previously perhaps they didn't have such good access to. There are plenty of studies on hypnosis and pain, but the point's already been made that doing randomized controlled trials isn't always easy, and it's certainly impossible for a single hypnotherapist. But there is a lot of evidence, and I would encourage anybody who hasn't had any experience with hypnosis but thinks that perhaps their clients might benefit from it, obviously I'd be very happy to come and talk to you. We have a wide range of approaches in hypnotherapy.
Yeah.
For example, I might use dissociation, getting the client to imagine that they are their body is here and feeling something, but their mind can be over there, and it doesn't necessarily need to receive that message because it's a boring message and doesn't tell them anything useful. Or I might get them to use imagery of imagining that there's a dial that is going to just adjust that level. Apologies, Joe, I do talk about 1 to 10 sometimes. That you're going to move the dial just a notch down and see what happens.
It's a bit like CBT in
or the ACT, acceptance and commitment therapy.
Yes.
A lot of that, because I wrote the book about it.
Yes.
I mean, the course was very much that dissociation.
Yes.
Okay, well, no, there's another aspect just to bring into this pot. So I think Nushar is indicating we should perhaps start taking some questions. Is that right? So I think first of all we're going to take questions from Slido. Are there any questions here before we come to any ones from the audience? Any questions? Well, while we're waiting for Slido, should we just bring a mic up here? I'll be Fiona Bruce. It's the man with the hat. Right. Yeah, it's going to be recorded, so it'd be great. Thanks.
Dr. Shmuel, I'm a clinical research physician. The first question is about palmitol ethanolamide. Anybody has experience with the pain management with palmitol ethanolamide?
With, so what was the
Palmitol ethanolamide.
Palmitol ethylamide.
Ethanolamide. No.
Anthony, have you come across that?
So it's actually cannabinoid like a lipid receptor agonist, and at the same time PPAR alpha. So very good clinical results. A lot of clinical research is done about this, but about pain, general pain. And actually you can buy it without any prescription online, and it's relatively cheap. So, and the second question, Julian. So basically I'm just also have a little bit personal experience with my relatives and friends about PBM.
Yeah.
And the question is about the usage of a helmet with the NIR, near infrared therapy, which is central, actually. Yes. Do you have any experience?
Great, thank you.
It's a very interesting question because there are numerous studies where they're using transcranial NIR in post-stroke victims, and it's really quite amazing. I think it works on this process that I said earlier. It's this quaternary. It's not that you're dealing with the brain because you've got to get through skin, you've got to get through bone. You're actually dealing with these very interesting protein molecules that thankfully through COVID we know more about, chemokines and cytokines, which help transport this irradiated blood and fluids, however it is, to target areas. So it is a very interesting field, and something which there are lots of RCTs on laser therapy. There are some very poor ones. The biggest problem, I would say to anybody who's interested in it, is actually where I really want to make a difference with all of this is in dosage, because there are lots of different bits of equipment, varying amounts of dosage, varying spot size, time, and really, if we're going to take this forward to the next generation, I think we need to sit down and come to some agreement on what is at least a safe dosage. I mean, there isn't really anything that's dangerous about it, but a safe dosage meaning one that's effectual.
Okay. What's your specialty? You're a pain specialist?
No, I'm not a pain specialist. I'm a clinical research physician.
Right, okay.
But I became interested in especially PBM recently.
Yeah.
Because of my father and relatives and friends in my community where I live now.
Mm-hmm.
And so I just, actually tomorrow I'm receiving the helmet from China.
Fine. Okay. Well. Okay. Good. Well, we've got
Check
a number.
The plug first.
We've got a number of questions, and probably there are two which I think are important, and address the same questions. What do you think about the disparity in treatments and treatment plans between the NHS and private sectors? So, Anthony, I'll ask you that first, because you've been in both
Yes.
areas. It is an issue that we're talking about treatments which are they're privately based, not accessible to 90% of the population.
95%.
And Julian, I'll come to you as well about that, and Elliot. But
Well, I think there are disparities. I did my best to set up a clinic at the Royal Free that did give plenty of time to each patient to discuss everything and so on. And I left the NHS before it was so protocol driven that you had to prescribe drugs that you really didn't think were the right thing. But I think time.
you had to follow algorithms, did you?
We didn't
you
have
could
to.
go down.
No, we didn't have to follow algorithms yet, which were written for economical reasons, I think. But there are disparities. But and time, the amount of time, and how often you can see a person, I think, is the biggest difference. Because
Yeah, and that's the message you get, is that time that Julian and Elliot spend with their patients, laying on of hands, is a huge part of
real
the whole
advantage.
treatment of patients.
And if you have time, then you can be what I call a good old-fashioned doctor, a good old-fashioned clinician. You could use interpersonal relationships as part of the therapy. If you've only got 10 minutes, you can't really do that.
Yeah. Julian, do you want to comment on that?
I was only going to say that we are very, very lucky as osteopaths to that the initial history is very important. Then we go through observation. Then we go through a palpitation where we're feeling palpation. I go through palpitations. You go through palpations. Then you go through testing, and so all the way you're building a picture of that person.
The other thing that you and I are using are not only these. It's our super antennae. We're just sensing things about the person and how
Listening.
they feel, and working on that as well.
Yeah, I mean, you've got that whole empathy role of it, which is what patients really want, in a sense. All right, Elliot, do you add on to that?
just say obviously a lot of the NHS is dictated by the NICE guidelines. So perhaps we can speak to Jo about this, and she might be in a position to help. Because once we get a treatment onto there, suddenly that opens it up to a huge number of more people. Which
okay.
is,
Yeah. So.
Actually, my question is very similar to what you just asked, Hadi, and the question that's been asked. And can I ask David this as more as a member rather than a panelist? I think most of my work is sort of on the NHS, and there's understanding and appreciation that drugs don't really work and that we need better treatments. And as you can see, better non-drug treatments, many of them. How do you think we can go around choosing what would be the next organic next step? If you have 5 little devices in front of you, each saying, they improve the odds of pain improvement.
I'm saying it's just as depressing with you as a doctor not being able to help your patients.
We want to help.
Yeah.
But
and we're limited
and then
in what
you
we
need
can
to
do.
choose how to which one to
David,
use.
do you want to answer that one? Difficult.
Well, I think having good enough evidence for 5 different treatments would already be an improvement to the current state.
I thought,
So, I don't know how to answer that. It is impossible, and as a clinician, you know, there was a lot.
So it's going to be evidence. It's going to be data, robust data, which will then help guide you which level treatment
this
is.
Is where I think NICE will come a bit stuck in how it's going to explore things like RTMS, the phototherapies, the hypnotherapy, etc. This is the challenge for the frontline sort of clinician, and also for someone who's sitting on these guidance committees to try and teasing out. And I think a lot of this at the moment is done on economic grounds, but it needs to move away from economic grounds to some extent.
And Anthony,
I think that, and this is not my original idea, pain has a particular problem with NICE, or one day NICE will see that they have a particular problem with pain. And the thing about pain is that the population of people with a particular pain condition is not heterogeneous. It's a whole series of subpopulations with different genetics, different life experiences, and different this, that, and the other. And therefore, that fundamental statistics that governs the randomized controlled trial that NICE is so fond of, where there is a bell-shaped curve and you say where population is, doesn't really apply to all of those subpopulations that pain people present as being from.
It is incredible, isn't it, that in 2021 we still have stuff being advertised on television for your back pain and your neck pain. There isn't a single medication that is approved for neck pain.
So I stood at that podium on this stage, and this was another meeting we held, and somebody pretty senior from NICE was good enough to come and stand here, and we spoke about this problem with the model, and I quoted one or two people that had said this, and he had the good grace not to disagree with me. And so I think that's an area that we need to work on with NICE.
Okay, well, let that come back to you, Joe. There's a question here. Of all the modalities and treatment, new options you've heard about, which ones appeal to you as a sufferer of painful neuropathy? Which one do you think?
I like something I can control. The thing that I don't like is being given a medication which removes my control, as the well-recommended drugs all do. I like the idea of the light treatment because it could regenerate, because it could actually be curative, not just numbing pain, it could be curative. I'm also very interested in the whole possibility of different ways of using cannabinoids, because a friend in London had been prescribed Sativex for neuropathy, so I trotted to my doctor saying, I want that, I just had a squirt, and it worked. And I was told in order to get it, I would have to go through all of the drugs I had already had in the same process right up to the maximum dosage to prove they didn't work before it would be considered, and even then it might not be. And I just thought, no way, not going there. CBD oil, the different strengths, a clinician recommended it to me before Christmas, and I was very doubtful. And I've now tried 1,000, 500, 275. And it certainly works enough to help me sleep. And that's what I'm using it for, to sleep. So it has some sort of benefit.
And it's not taking anything away from it?
No, it's not. I'm still here. The thing about medications is they take this away. And that is what you really do not want to lose.
Thank you very much. So there's a question from Alan Cole. Management of patients seems largely trial and error and empirical. Do you think any investigations are indicated or useful, presumably to help decide what treatments to use? David, any thoughts on that?
I mean, that's the holy grail of pain research, right? To personalize treatment in a way that you can screen patients in a manner that tells you that you have a relatively high chance of finding of success with a particular treatment. And the narrative here really was more around experiential decision making, and I think clinical practice does incorporate or does consist of those two elements. You need to be able to appraise evidence. Researchers need to be able to prepare evidence in a manner that reaches the end user, which is usually the clinician, and allows them to make decisions, but that then needs to be discussed with the preferences of a patient, with what's available, with what's affordable. But yeah, we are probably moving not very fast in the direction of personalization. Things that we thought were working, like the start back tool for low back pain, again, first trial shows a successful response. The replication doesn't anymore. So even with back pain, it is really hard to stratify people into 3 risk groups and then target treatment.
Okay, well, we'll take a couple more questions. We've got some questions from the audience. What about the cost, Elliot? What about the cost of your magnetic stimulation? Give us an idea, and then of your laser therapy, because I have absolutely no idea what we're talking about.
Yeah, I mean, at the moment it's produced in relatively small scale, so the cost is not insignificant. So I think the machine itself is about 20,000, and obviously you need to pay somebody to apply it as well. That can be anybody. So in psychiatry, nurses often apply it, osteopaths
But in
can do
terms
it,
of cost
physios
to the
can do it.
individual patients, if I come and see you with my neuropathic pain,
Yeah. So in our clinic at the moment, for a full treatment of 20 sessions, it's £5,400.
it's a fair whack.
So it's a fair
Triggered a cough there, you know.
Triggered a cough, yeah. It's not cheap at the moment, absolutely, yeah.
And is it recognised by the insurance companies, just out of interest?
Yeah, so for depression it is,
But
not yet for pain, because they base their recommendations on the NICE guidelines.
So that's a fair whack of money, really, isn't it?
Yeah, absolutely, yeah.
Julian, what about your treatments with the laser? What are we talking about if I came to you with my neuropathic pain?
I think that generally, for my treatments, it's somewhere around £150 a session, which is for an hour. That doesn't mean to say that that is the cost of the treatment, because the equipment is expensive.
Yeah.
To get good equipment, you can buy stuff like your thing that you're going to get through, which is you know, it can range from $50 to $600 for exactly the same kind of helmet.
The helmet.
Yes. Or $2,500 exactly, cheapest one. So there is a huge price change
costs.
here.
Yeah.
There is a huge, but actually once you've got the equipment, the same with your equipment, it's incredibly cheap in the long term.
For the individual patient, it's about £150 a session.
Yeah, but it might be less than that in certain. I mean, I'm based in central London, where we have, Howdy Warden, who kind of making us work hard. But if you're in an area, it doesn't have to be that much.
No.
I think it doesn't have to be that much at all.
Anthony, what about the cannabinoid treatments?
Yeah.
Clinic appointments, cost of the medications, the good to pay for the costs. How much is it we're talking about?
Well, you probably need to see the doctor 4 or 5 times to titrate the right medicine for you. And then after that, you can mostly see the nurse on a monthly basis to get checkups.
There's the consultation fees.
So there are consultation fees, and there are the cost of the products themselves.
What do they cost? I mean, how much?
They're coming down all the time, but I think most people can manage on one oil. Will have to pay for that oil about £200 a month, maybe 150 if they're lucky. Plus, you've got to pay to see this guy, I'm afraid.
Yeah. Okay.
But if it's a regular thing, that doesn't become terribly expensive. But if it means that you can go back to work, or if it means you don't have to pay somebody else to care for your child, then actually there's an economic value in it.
We've had, as the doctor said, we've had lawyers go back to work. We've had people go back to full-time employment. So then £5,000 to them is actually
it's
very
an
little.
investment.
And although we're talking about peripheral neuropathy, a lot of my patients are professional sports people. And for them, the difference in being able to go back and work, I mean, it's enormous.
Prasad, do you want to add something?
I'm just going to ask Anthony one question. Where in the ladder of these things, or do you not believe in a ladder?
Yeah.
Where would you see and start cannabinoid oil? It is a kind of a pharmaceutical agent, but not a pharmaceutical agent. Where do you see it being placed?
That's a very good question. The official answer in the UK is, well, you've got to try 3 or 4 conventional things first. But we're following practice in Canada, where they are 5, 6, 7 years ahead of us. And they will pick out a patient who they know will do well on cannabis medicines.
Right.
And I think I'm in the same place. I don't want to make you sleepy on amitriptyline. I don't want to get you addicted. If you've got fibromyalgia, this is what is going to help you.
Okay. Great. So let's take some questions from the audience. I'll be with Fiona Bruce here. The gentleman in the orange sweater.
Excellent session and very good innovative ideas, which we have certainly learned some new things from the panelists. Just a thought, the chronic anxiety that is associated with any chronic pain condition, i.e. neuropathy, post-herpetic neuralgia, or similar kind of things, presumably increases the pain threshold. Has there been any work done to look at certain things which might address these issues, pain threshold and anxiety, like anxiolytics?
Well, I think one of the reasons that people get so stuck on so many medicines that are not reducing their pain, whether it's morphine or gabapentin, is because those drugs are treating the anxiety. And when the person stops taking the medicine, the anxiety comes back. So you're absolutely right, I think, to link the pain and anxiety so closely together. Hadi, dare I say it, that the cannabis medicines do address the anxiety.
Okay. Any other questions from the audience? Yeah. Just wait for the microphone, thanks.
Thank you. Could I ask David, has there been anything you've heard tonight that might change the scope or way in which you're doing your research?
Which I'm doing my research in terms of what I would put into that multimodal treatment.
Into the compilation of what you're looking at in order to develop your reports on the tests you're trying to do.
If 3 years of PhD with Professor Andrew Rice teach you anything, then it's to be a skeptic. So I would really want to look at the primary data for all of these interventions. Not to say you can't make really good experiences with them. Patients can make really good experiences with them. But to make decisions, whether you put something into a basket of what's offered generally or not, I think you do need high quality data. So no, at this stage not, but I'll go away and
because as with
have
pain,
a look
as with all the other types of like migraine, the placebo effect can be huge.
Huge.
And that's why you need the good data to get the appropriate therapies online.
But I'm a skeptic with all the other, with the interventions that I put into my own multimodal treatment. It's the same thing.
Any other questions? Yeah.
Yes. I'm a radiation oncologist.
Should we just wait for the microphone?
Sorry.
Yeah, no, that's fine.
Hello, Gordon Reed, retired radiation oncologist. Fascinated by your discussions. I'm just wondering, Elliot, you described all the pros of your intervention. We haven't heard any discussion about disadvantages, side effects, long-term sequelae. Would you have you any?
Good question. Yeah.
Any data yet which is showing? Sorry, it's the negative side of things, but I think it's important to consider.
Absolutely, it's hugely important. Yeah. Most of the data is on depression treatment. That's been going on for 20 to 30 years. But as I say, it works on the same mechanism. It's the same treatment, and the safety has been excellent. So I think about 10% of patients experience a short-lasting headache after treatment. Other than that, there is essentially the risk that you take is that it might not work. That's, you know, there's a certain percentage of people who are non-responders. In terms of contraindications as well, the only things that we don't currently treat or that will exclude people from treatment is if they have any kind of metal in the head, so cochlear implants, metal plates, things like that. And also some places are careful with treating people with epilepsy. I think there's about a 0.003% risk of seizure with it, which is
so
about
there are some
which is about 100 times less than the risk that comes with antidepressants.
That, of course, is on a logarithmic scale, is it not?
Yeah, absolutely.
Thank you so much.
No problem.
Final question, lady in the orange sweater. and then I'll summarize. We'll close the meeting.
It's very quick. It's not a question.
Good.
It's a comment. I'm a podiatrist. I've worked in central London in private practice and in the NHS actually for over 40 years. I've seen many, many patients with peripheral neuropathy, a lot of diabetics, alcoholics, patients who come in with peripheral neuropathy who sometimes don't know the cause of it, and the medical profession never get to the base of it and the cause of it. They're very fearful. They're very at risk. They can't feel their limbs, as we know. So they're very at risk from injury, and my profession
and alteration. Yeah, thanks.
deals with that a lot.
Okay, thank you very much. So I think it's time to close the meeting. So how am I going to summarize this meeting really? The first thing I would say is just listening to the panel, I think there is optimism in terms of treatment of painful peripheral neuropathy. That's the first thing I would come up with. We've got combination therapies, which have been shown in good studies to be helpful. So combinations of pregabalin plus duloxetine and the others. We've got magnetic stimulation, central and peripheral, which I'd never heard of. Sounds promising, but we need the data. We've got laser therapy, again promising, but we need good data. And then we need the right sort of trials for multimodal therapies, which I think are combination of psychological and physical treatments. I think that's what I would summarize as what we've got from the panel, really. And maybe I'll just give the last word to Joe, really.
Gosh. No, that wasn't
You
the
start-
last word. No.
You started, you might as well finish.
Well, one thing I would say is how interested I've been to hear all of these very different perspectives. And one thing I would really like to see is there being more opportunity for people who do suffer from peripheral neuropathies to A, be diagnosed, and B, actually have the opportunity to see people who can offer them therapies. Andrew Rice, who you know awfully well, was in fact the pain specialist I saw that led to me understanding what was happening to me, for me, and I think for many other people, understanding what is happening.
So it's a referral to the right person, really.
Yeah, and it's fundamental though to understand. If you understand, you can get past it.
Good, all right. Well, just to close, I mean, I'd like to thank Joe. Thank you very much for being the patient representative, the panel, and to Linda as well for kicking off this meeting. Thank you very much to the Diamond family for funding this. Roger, do you want to add anything more before we finish?
No, not really. Just to say thank you to everybody for coming. Thank you to Fiona Bruce, alias Hadi, tonight. Fantastic chairmanship. And so pleased that Michelle didn't get a call halfway through the meeting from Alan. So, Alan, if you can see us, thank you so much, because without you, we couldn't have put this on this evening. Good night, everybody.
Thank you.